1st of December, the world marked International AIDS Day, which is an opportunity to people living with HIV/AIDS, with the theme this year, Right to Health for All. Obviously, Tanzania joined the rest of the world to mark the day with its own local theme, which was Contribute to AIDS Trust Fund, as opposed to save lives, because money is not coming in as expected. The government, through the National Bureau of Statistics, also released preliminary results of the 2016-2017 impact survey on HIV/AIDS, which indicated that the number of adults living with HIV/AIDS in the country is estimated at 1.4 million people. We are glad that we have Irenaeus Ruyobia from the Bureau of Statistics, who is also director of statistics operations, to help us with these figures. So to discuss the implications of the impact of the survey data and where we are with the fight against HIV/AIDS, and how people living with HIV are feeling in the society, whether they're still facing stigma of some kind, which was previously the case in many years when this thing was reported. Now, I have with me today a very interesting and capable team. On my right is Emmanuel Bayingana from Joint United Nations AIDS Program, United Nations Joint Program on HIV/AIDS, based in Dar es Salaam, more or less representing the advisor or the head of the unit. It's an interesting international organization, young as it is. Next is Irenaeus Ruyobia, who is from National Bureau of Statistics, but his exact work, their position is Director of Statistic Operations. On my left, you have Dr. Jeremy Kamwera, who is Director of Monitoring and Information of TACAIDS, that's Tanzania AIDS Commission. Last but not least is Gregory Kamugisha from the National Council of People Living with HIV/AIDS. You know, I heard about this organization recently. All right, I never read much about it because maybe you are not so much in the news. Okay. So, gentlemen, welcome to the program.
Thank you.
Thank you.
Okay.
As I said, in the next 55 minutes, let's try and if not educating, but make viewers aware of what's going on in this fight against HIV/AIDS. Okay. So the very first question, and I would like this to be responded to by Irenaeus from the Bureau of Statistics. With the latest statistics or data from the 2016-2017 impact survey, what exactly, in your view, from a statistical point of view, is the status of HIV/AIDS in Tanzania? I'm sure from TACAIDS we hear much more elaboration, but from statistical point of view, do you want to come in here?
Yeah, thank you, Mr. Simbeye, and thank you for that question. Maybe before I give my view on the status, what I said the status of HIV in Tanzania, let me start with the numbers.
All right.
As you said correctly, on the 1st of December, we presented the preliminary results of the survey that we conducted in the country.
Yes.
This was the 4th survey, not exactly the same, but on estimating the prevalence of HIV/AIDS in the country. Mm-hmm. The first one was in 2003, 2004, and the prevalence by then among population aged 15 to 49, I must state that one, was 7%. Mm-hmm. That was in 2003, 2004. We had other surveys in between, but the latest survey showed that the prevalence rate now among that age group is dropping down to 4.7.
Okay.
In the last survey, it was 5.1.
Yes.
So you can see that
The
it's
trend
like
is going down?
going down and stabilizing, maybe.
Right.
Yeah, maybe I should
Yeah.
stop here at the moment.
Okay,
Yes.
that's a very good introduction statistically, and it does make sense for the viewers to understand where we're coming from and where we are. I suppose where we're going.
Yeah, sure.
But where we are going will be subject of response from the three panels. Dr. Kamola, from TACAIDS, you had very, very briefly the statistics, which are impressive in the sense that actually the trend, prevalence is going down. Is this the case you're noticing, and you share this statistical evaluation? What's the status of HIV in the country?
Yeah, we are seeing what we call a stable decline. Now it's about leveling off between the last two surveys. That we've been seeing a very pronounced decline, but now between the two surveys, it's somewhere where we think the level is stabilizing, because the statisticians will say the difference between 5.1 and 4.7 statistically, very marginal, which in part is not a bad thing. It's not a bad thing, because one thing that people should know is it will reach a point where people who get HIV and AIDS don't need to die, because there is treatment.
As in the past.
And therefore, if you count them,
Yes.
their numbers possibly will be increasing. That people who acquire the infection, but still they live because they get better treatment.
Okay.
Yeah, so there is a point that we don't like to see such a sliding. But there is another measure to it.
Yes.
What we look at is the new infections.
I mean, opportunistic infections?
No, new
or
infection,
just
new
infection,
HIV
HIV?
infections.
New infections.
The figure that my colleague provided is that at any time, what percentage of the population is living with HIV and AIDS? But for us to be able to see the difference, whether HIV infections are going down, we need to start tracking how many new people within our population
Yes.
acquire the infection.
Is it particular age group 15 to 49?
15 to 49, and also this time we are doing 15 to 64. Yeah, that's a new.
And not below 15.
No, we do even to 0. Actually, the
This time
current
it
survey started with 0 to 64. But the previous one was actually 15 to 49.
Why 64 and not 70 plus? Because I'm 70 plus.
And you are not covered.
I'm 75 now.
Yeah.
So let me finish this point first, and before we come to that.
We responded to my problem.
So we also do kind of mathematical modeling to see how many new infections appear in the country in a given year.
Yes.
I think in 2013 we had like 79,000 new infections, but last year we had 55.
Okay.
So you can see the trend going down. So we are sure that the infection is facing a decline. We are doing a good job to ensure that few Tanzanians acquire the infection, and those who acquire the infection, yes, live a healthy life.
You're more comfortable that there could be more people being infected, but they don't die as in the past. Few die. I mean, dying is, of course, they will die, but few are dying because of the effect of HIV/AIDS.
Let me put it this way.
Yes,
We don't want people to get infected.
in the first place.
That's number one. Our interest is to see fewer people getting infected.
Yes.
But in case one gets infected, then has to live a healthy life. Yeah?
You didn't add the word longer, but just healthy.
Yeah.
Yeah, of course, it is healthy to be.
It's about the same. Yeah, it's about the same.
Okay, that's very interesting. Let's hear from by Ghana from UNAIDS. For you, I will also add a little, well, not a little, but one aspect here of the same question. which is number 2, if you read properly. Has the number of people living with HIV/AIDS increased or decreased since the last impact survey been responded to? It's been responded to. But how is the global picture on this issue? Is it just as serious as it was first pronounced? I think it was 1980 or something, when the first aid was reported, although it was there, but people, the medical profession or the scientists had not really actually discovered what it was until maybe 1988, 1983. So what is the status globally? And then we'll come to the neighboring countries.
Now, what we see here in Tanzania
Yes.
is what is happening globally.
Okay.
The number of people dying from HIV has drastically decreased. And we attribute this to the introduction of ARVs. People have been treated since around 2002, in Tanzania 2004, and we see a drastic decline in the number of people dying. We see a decline in new infections, but not as fast as the people who are dying. I think it's about 28% decline, I think in the last 10 years or something like that.
Declining
In the new infections,
Okay.
there's a decline, but the trend is not as fast as in death.
I mean, the trend in death is
faster.
I mean, more people
More
dying
people
faster.
reducing
The decline.
the
decline.
decline in the number of people who are dying. We have fewer people dying
Yes.
than it was about how many years
13
ago?
years ago.
About 10 years ago, about 13 years ago. We see fewer people getting infected, but not as fewer in the numbers as the number who are dying. We, in terms of what we call vertical transmission, the number of children who get infected from the mothers,
Yes.
we see
Mother to child.
mother-child transmission. There is a very steady decline. You know, fewer children are getting infected from the mothers. But our aim is to get 0 new infection. Actually, that's what we want, the aim here in Tanzania. 0 new infection, 0 death. And then he will talk about 0 discrimination.
Okay.
He'll
I'll get
talk-
to you,
he'll talk
Gregory.
about
A couple
that.
of things you have to.
I'm waiting.
But back to you. Oh, sorry, you didn't switch your phone off. I forgot to tell you to switch your phones off. But it will be muted when we do the editing. If the aim is to reduce the rate of infection, mother to child infection, and you say it has actually declined, what have you done? What has been done? You want to take a demand to respond?
I can
Please
start
go
and
ahead, and then you can reinforce.
Yes, you see, in 2014, I think,
Yes.
2013, they introduced what we call, it's a part of treatment option called option B+. In other words, every woman who is HIV positive, when a woman is pregnant,
Yes.
she's supposed to go for testing, ANC. Testing.
Immediately,
Antenatal-
or as
antenatal-
part of
normally.
as part of a
Yes, you are
antenatal
antenatal,
service.
yes. You are supposed to go for the checkup,
Yes,
Antenatal care.
antenatal care for the checkup. And once you come, they test you for HIV.
as well.
Yes, they test. So I think over 80% of the women are tested. So they test you. When HIV positive, they put you on treatment.
While you're pregnant.
When you're pregnant.
I mean, not you. While she's pregnant.
When she was pregnant, they put her on treatment.
Yes.
And that treatment prevents the infection from
Mother.
going to the child,
The unborn child.
the unborn child.
Yeah.
Either at delivery or during breastfeeding.
Okay.
Yes,
So this is why these days a positive mother will deliver a very healthy
Yes.
kid,
Yes.
non-infected with
Yes.
HIV/AIDS
Yes.
because of that.
Yes.
But
You want to amplify?
one thing he hasn't told you about mothers going for. A woman does not save you from going for it.
You could be
you could be infected.
But men are not cooperating.
But men are not
Men are
cooperating.
men.
Women are not cooperating.
Women are not
Women are
cooperating.
cooperating.
The five of us here are men.
They
The
are-
five of us are men. So who is not cooperating? The
Men.
men
The men.
or the women are not bold enough to
To
tell their
husbands.
husband that, look, this is what is happening, you better come along, so that they also find out whether you are or you're not.
Actually,
Yes, Dr. Kamal.
this has a cultural perspective. You know, naturally in African society, Tanzania included, women take care of the family, take care of the sick. So they are the ones who go to the hospital and the healthcare facility more often than men.
Yes.
The man will give a fare and a fee for treatment to the wife, and the wife will take the kid to the hospital, not the father taking the kid to the hospital.
Although once in a while I've done that.
Yeah.
My wife would dispute with this, all right.
Yeah. So what is happening is men consider themselves that going to get tested is going to hospital is a sign of weakness somewhat. So they have very little contact with healthcare system. They are the least users of service in any case, and they access services when they are very late. And in HIV and AIDS, men usually die a lot more than women, though the burden is the opposite.
The women.
If you compare men and women,
Yes.
you have more women who are living with HIV than men.
By far.
But when it comes to outcomes of being infected, you see that many men are dying than women.
Because of
And
the
if
same
you
problem.
check, if you check service utilization, you see more women accessing services
Yes.
than
Than
men,
men.
and that explains why we see more deaths among men. So the challenge is that we have now is men
convince
involvement
Yeah.
in accessing services and supporting their partners to access the service.
They
That
need
is something that maybe we'll talk as challenge.
You need education,
Yeah.
basically, and I suppose this is part of the responsibility
Yes,
of
exactly.
the TACAID.
Yes,
Are
exactly.
you doing that?
Yes, actually, if you had followed the last World AIDS Day, that is one of the area of thrust that has come up very, very well. We have been instructed now to go and look for men, educate them to the point that they are empowered to take control of their own health and support their families, and not the other way around.
You will have to go to the bars, to the local brewers.
Wherever they are.
We
wherever
have
they-
started, but I think
Wherever
we'll
they
have a grand plan this year.
All right. Okay. Now,
I wanted to add on that point.
Yes,
I
before we
miss- I
ask
miss
Gre-
it, yes.
Gregory.
You see, when you look at people who are accessing treatment,
yes.
about 45% of the men who are sick are receiving treatment. 45%, compared to about 73% of the women.
Of the women.
So men, if you are sick, you are sick. They don't want to go for treatment. It is free. They don't want to go. And then it now translates to death.
Outcome.
When the outcome. So the data we have, the mathematical modeling he talked about, we model the impacts of HIV, and death is one of them, as I mentioned. In 2016, we were estimating about 33,000 people who died in Tanzania due to HIV.
33,000
33,000.
out of the total population?
We are talking about 1.4 million
1.4
people
million
living with HIV.
Total living with HIV.
Yes.
Yeah.
Then of those, we are looking at around, of course, 1.4 million were alive. So those who died, because we have new infections, so 33,000 people died. Of those, women who died, women who are 15 years plus, who died due to HIV is 9,000.
And the rest?
Then children is 6,500. So basically, about 15,500 is women and children. The balance is men.
So more men are dying of HIV.
Yeah.
Yeah.
Does HIV kill? Doctor, you say die of HIV.
You will die from AIDS-related complexes.
What you
or
call in medical
conditions.
science
Those are
opportunistic.
opportunistic infections.
All right. Okay. Now, Gregory,
Yes.
you represent the council which is representing people living with HIV/AIDS. How do you go about doing this? Because there are so many fundamental questions. First, there's a question of stigma. There's a question of not revealing your status. As you said, men don't go to the hospital.
Yeah.
So how do you approach this? And to say you are handling people living with HIV/AIDS?
It's not like the question of you are handling them. As the doctors have said, we have like 1.4 million people
Yes.
living with HIV in the country.
Yes.
And that size of population is bigger than like the population of Singida or Katavi or Rukwa or Lindi from the last population and the housing census.
Okay.
So it's a huge population. In the sense it's mixed among the entire population.
Yes.
Usually you do not know where the people living with HIV are or where they are not, except when they come out themselves, voluntarily test, and are willing to declare their status. And largely that's how we get to know where the people living with HIV are.
If they don't come forward,
It's very difficult. You can't tell where they are. You cannot look at somebody and tell this person is living with HIV and this one is not. We are all looking the same, especially now with ARVs freely available all
like
around.
if you look at me, Mzee
I
Simba,
cannot tell whether you are living with
you can
HIV
tell
or not.
eh?
I cannot. So you have to be bold and come forward, take the test, collect your results. And it's good if you find yourself positive, open up, disclose your status, and seek treatment. That's what they have been telling us, and I think that has been very helpful.
Do you think? Do
Yeah.
you think the ARVs
Yeah.
are actually working? Because you
Yes,
you are
yes,
with
yes.
people living with HIV.
Those of us or even the viewers who were there in the mid-80s, early 90s, when AIDS was ravaging societies, people were dying everywhere. You don't see much of that today.
Even the regions, specific regions, were more or less the leading in number of people dying with HIV/AIDS.
It has changed significantly. It has changed quite a lot, yeah.
What has helped? What do you find as being helpful?
Admission to antiretroviral therapy.
Not cultural?
Cultural might be there, but not as much as what we have seen from ARV treatment. That's what has changed the history of the disease, I could say, in general.
Not
Yeah.
preaching in mosques
Oh, of
and
course
churches, because I hear
Curing
my
flu,
church,
prayers.
they talk so much about HIV/AIDS in part of their sermons everywhere. So you don't think
Those
this has
could
helped?
be very, very insignificant if they really work.
Actually, I think
they were-
if I might add something,
Yeah.
the preaching, the religion interventions, and
Cultural.
cultural interventions, they usually work for people who have not yet succumbed to AIDS. Because now it tries to make people be aware, hey, if you do this, you're going to get infected and then you'll be sick. But once
it does scare them, isn't it?
Yeah, somehow not really scare, but make them be aware, more aware, because we want them to be aware and should know what to do. So if you don't want conflict with your God, you don't sin and you don't do those kind of things, then you may, in the way, avoid having infected. But once you are infected and you start developing AIDS, the only way for you to be safe is getting ARV. That is what will change your cause of outcome from a certain death to a healthy living. So that is where the power of ARVs has been very vivid. People who were bedridden, all of a sudden they're good looking, they're back to work, they're productive, then their families are happy and everybody could see. So that is where...
So you'd say advancement in medicine and all in science has contributed a lot towards this?
Yes, very much.
Okay. Mr. Yobia,
Yes.
or Renews, the statistics released, which your organization released, actually, the chief executive, Dr. Albina Chua, released on the 1st at Mnazimoja, is it?
Yeah.
Yeah, the World AIDS Day.
Is it part of your priority, part of your regular activities to go into looking at the situation, HIV situation in the country, so that you get the data? And are you being asked by someone to do this, or is part of your priority? For example, does TACAIDS or National HIV/AIDS Control Program say, please do this for us, or what?
Yeah, let me say that the survey conducted, not only this one, but even in the past,
Yes.
we don't do it alone. We do it in conjunction with the others. You know, for example, this one is about testing. And at the NBS, we don't have medical doctors. We don't have nurses. We have the knowledge in statistics.
Yes.
So, in fact, the NBS is doing it on behalf of TACAIDS, on behalf of the Ministry of Health, on behalf of the government.
Okay.
And we do it together.
Okay.
He's a member of the technical committee. He's a member of the technical committee. So we do it together. We don't just do it for sake of doing it, but to get information to inform decision makers. Where are we and what should be done? Where are we going wrong, so that we can rethink on priorities.
Okay.
Can I add a little bit?
Yes, Dr.
Yes.
Kamwela.
One thing is HIV response in Tanzania. We have a so-called National Multi-Sectoral Strategic Framework for HIV and AIDS. It's a 5-year strategic plan that shows what needs to be done in responding to HIV and AIDS. That means from health sector, education sector, every facet of response to HIV is in that national document. Now, from time to time, we need to do evaluation to see whether are we delivering as the strategic plan specifies. Now, this is where we turn to the people with the right technical specialization to do this kind of measurements. So one measurement is the survey, and NBS is mandated by law to do that. So they help us to do the survey, and we use these to measure how good are we in implementing the National Multi-Sectoral Strategic Framework. We also do modeling, me and Emmanuel and a couple of us, for some of the areas.
When you say me and Emmanuel, you mean
TACAIDS.
TACAIDS, UNAIDS, we have people from NACP, from
WHO?
CDC,
Yes.
WHO as well. We have a national team where we sit and do modeling. But we also have routine data from facilities that provide services. That means Ministry of Health collect information from facilities. NACOFA also collects some information on what is being done by its clusters in all the districts in the country. And we summarize it to inform that this is how the picture is, and what are the performing area, what are the weak area, and what needs to be done, so that now the big people who can make decision now can see this is where we think we should be looking.
this is where the money should go.
Yes, exactly.
Now, Gregory, in NACOFA, are you spread all over the country, or you're just confined in Dar es Salaam?
No, NACOFA is organized in clusters. These are associations of people, individuals living with HIV groups, networks, clustered in districts. Currently, we are in 154 districts all over the country. They have got their own leadership, the chairman, the deputy chair, the secretary, the treasurer. They conduct their own businesses where they are. But we get information from those clusters to the Dar es Salaam headquarters, and we share it with the government.
What is your support to these individual organizations that is used?
Technical support. The head office is representing them in the policy-making bodies. We work with the parliament, we work with the TACAIDS, the Ministry of Health,
Global Fund.
the Global Fund and the UN theme.
That's Bill Gates and his wife. Huh?
Well, those
All
could
right,
be part
all
of
right,
the partners
all right,
we'll be
okay.
working with in
Okay.
the near future. We are actually
Okay.
discussing with them as well. And we get their suggestions, the challenges they're facing, and when we put those together, that's how we get the national reports. Yeah.
Do you get feedback from your associations or the clusters all over the
Yeah.
country, whether or not there's still some element of stigma with the people living with HIV/AIDS, and what exactly is the approach to kind of
Stigma
help
is a cross-cutting behavioral attitude thing.
yes?
It's within the people living with HIV themselves, but also in the entire communities. The National Bureau of Statistics measures, they have put some indicators to measure stigma, and they've been doing this like for the last 15 years. So you can see some trends on how it is changing. Generally, it's going down, but it's still very much there.
Does it vary from one region to the other?
The major diversity, I remember, it's higher in rural areas than in urban areas.
Even within the regions?
Yeah. It's higher among women than in men. It's higher among the less educated than the more educated. Those are the major distribution components of it, yeah.
Irenaeus, he referred to something that you also do, this question of stigma. What does your impact survey state? Is it exactly what Gregor says, or there's more to it than what is seen in the eye?
Yeah, what he said is true. And the diversity mentioned about rural, urban, educated, and uneducated is true. And this one is a preliminary. When we come to the analysis itself, we could also see what will come out of 2016 survey. But that's what has been observed in the past survey. Remember, I told you this was the first survey, and we measure stigma. And as I said, it's possible linked with the culture, but also with the knowledge. Yeah, you know, people in urban areas are more likely to know about how it's transmitted than people in the rural areas. People who are educated are more likely to know that you cannot contact HIV by shaking hands.
With somebody.
So I think
No, by sharing plate of ugali?
yeah, something like that. Something like that. Yeah. Yeah. So let's wait to see what will come out of this one. But I can predict stigma going down. But differences between different social groups to continue existing. Yeah.
And it being a behavior, it's like there is no very quick solution to that. It can change, but very gradually. Yeah.
Any one of you can respond to this.
Okay.
Do I take it that there's higher prevalence of HIV/AIDS in men or lower in women, or vice versa?
Generally,
Yes.
sorry, across all surveys,
Yes.
prevalence has been higher among women than men. Even this one. Actually, in the last two surveys, it's almost 6 by 4. Yeah, 6 by 4.
Yeah.
6 for women, 3 for
men.
men.
So 6 women, 4 men.
Yes.
Yeah.
And what explains this variation of the prevalence rate between Southern Highlands
Why?
town or city
The
of
regions.
Njombe
Yeah.
and Lindi, and maybe other regions? What explains it? Did you find this in your survey? What explains it?
Why higher HIV?
Why higher in
levels?
maybe in
Yes.
Njombe and Lindi and the very low in Lindi.
Yes.
Yeah.
Okay.
Maybe doctors will tell us. You know, I was reading in some papers. You know, like doctors were wondering why HIV prevalence is very low in West Africa compared to East.
Oh, is that so?
Yeah, I think
That's a
yeah,
good
yeah,
piece
actually,
of information.
Actually, there are some scientific facts, but also geographical distribution of the virus. One, let's go to Southern Highlands.
Yes.
Njombe is still leading. Now it's 11.4. Iringa is now has gone up to 11.
Of course, it used to be the same
Yeah.
region.
0.3.
Yeah, and then Mbeya is also 9.
9, yeah.
Yeah, you go to
I
Katavi, it's
always
around
thought
4.
Mbeya was very high.
Yeah, but
But
you
not-
know, it was in the same order after Iringa.
Okay.
Njombe, Iringa,
Iringa,
Mbeya.
Mbeya.
No change so far.
No change.
No.
The trend is the
It's
same.
the same.
And Rukwa somewhat. But you know, the more as you go south of Sahara, the HIV burdens increase. General prevalence in Zambia and other southern
Zimbabwe,
African
South
countries,
Africa,
Zimbabwe,
Swaziland, Botswana.
Swaziland is several times higher than us, maybe 3-4 times.
By far.
Yeah? And you should know these regions are just at the entry. Okay? Those are
Border po-
landlocked countries. They enter our country through Tunduma.
Yes.
Yeah? And there is a lot of interaction going in towards Dar es Salaam and back. So that is one factor.
Big trucks and truck
Big
drivers.
trucks, yeah, our roads are full of trucks and they're from southern African countries. And that can be part of the explanation. But number two,
Probably.
yeah, because we don't have we are looking at the
Scientific
possible.
explanation.
Number
Yeah.
two,
Yes.
circumcision prevalence.
Okay.
If you look at the prevalence of circumcision, it's very low in the region of Southern Highland compared
Okay.
to the coastal region.
Okay.
And evidence shows that chance of getting HIV between circumcised and circumcised
Non-circumcised.
person,
Yeah.
the uncircumcised person has up to 6 times higher chances of acquiring infection from infected woman. Yeah. So circumcision by itself can lower probability of getting infected by around 60%, just by that. So that is the second thing. Number 3, geographical, the climatic reason, what we call, those are cold areas. People get close together. They interact.
You mean we in Dar es Salaam are running away
No, I didn't
from
say
each
that.
other?
I didn't say that. I didn't say that.
Why is it?
I didn't say
No,
that.
he says yes.
When it's hot,
The data from THMS of 2012,
Yes.
you go and look at it. Then when they talk, for those who had sex in 1 year, you need
number
to look
of
at the data.
partners.
Dar es Salaam, very low. Very low.
And
Because of the heat.
Traffic jam.
in the Zimbabwe, you
Avoiding
know,
each
when
other.
it's very hot,
Yes.
men Swahili sleep outside. Eh?
Yes.
They don't
Half
sleep
naked.
indoors.
Okay.
Outside. And they
And half naked.
yes, and outside. Men
okay.
only sleeping outside.
But
But you,
not in
you don't
Dubai.
see in your place.
Oh, I mean.
So
John
the
Day.
other ways they talk of commercial interactions. There is a lot of international business in trade in Njombe on timber. People come from all over
The main road, yeah.
the place.
Tea and
Buying no timber, mbao.
Okay.
They buy these, you know. And there are a lot of men who are working in the plantations, just doing that, away from their families and without families. In Mbeya, you know, you have mining areas, which attracts a lot of men who stay away from families. You go to the areas where you grow rice,
Yeah.
there are a lot of movement of ladies and gentlemen doing business. So combination of those. make
It's
those
like
black
in South
areas.
Africa then, because of the.
Yeah. But one thing, when we are still discussing the prevalence, this year's results are giving something which I think is maybe worth being followed up and knowing why it's like that. some regions like Mwanza, Kagera, and the Tanga, the prevalence has gone up. It's getting worse than it was in 2011, 2012.
Which is, this is Mwanza and Tanga?
Kagera,
Dodoma,
Mwanza,
Tanga.
Kagera, Tanga, they recorded higher HIV prevalence than they had in the previous survey.
Even Dodoma.
Even Dodoma.
Yes.
So that could be worth being followed up to know what might be explaining that. Why is it like that?
Maybe that's a point Mr. Ruyobia with the National Bureau of Statistics can take note of that. And
Yeah, we can take note of that, and that's why we do surveys. One of the reason to do surveys is to come up with issues.
yes.
Now, doctors, others can take over these numbers and try to explain why so, and why some regions have very low prevalence. Rates.
For example, Lindi.
Yeah,
Lindi had 2.9, now it has 0.3.
Maybe male circumcision is 90%.
Yes, but where did people who were positive in the last survey,
Go.
where did they go?
And what about Mara?
Many
where
people
men
came
are
in who
subsidized?
was not circumcised.
why the rate is very low. For example, Zanzibar. All those years.
2 regions of Zanzibar, 0 prevalence.
Yes,
Complete
like
zero
does not
prevalence.
exist.
Which
Why?
means
Never
it's
happened
90% circumcision. Is
Yes,
that
that is one.
Maybe,
But you know,
but there could be some other reasons too.
so? Or because
Maybe
it's
we
too
don't know.
hot, as he says. Far away from it.
That was just a joke.
I
That
think
was
the message
just
is,
joking.
you know, if you look at the data, you try to, it triggers
Yeah.
some thinking.
Yes.
Lindy had 4 years ago, we do survey every 4 years. 4 years ago, the prevalence there was around 2.6 or 0.9.
Yes.
Now it has gone down to 0.3. So that should be something to
It must
follow
be
up.
a learning
Yeah.
field,
And we know
yeah.
that a lot of things now are happening in the Southern Corridor. We are having gas.
Businesses,
The road now is more passable. Influx of people in and out is even better. So that is what. But if you look at the data for Njombe, Iringa, Mbeya, very stable.
Oh, you mean no decline, no
Consistently high.
increase?
Very stable high
consistently
means people survive.
People survive.
But also we need to look at the migration patterns.
high. Okay.
You know, when you do the migration data study rather, you see the new infections in this country are more concentrated in younger age group. 15 to 24 contribute 40% of the new infections in the country.
Especially for women.
Now these are especially for women, but these are the young people. These are people who migrate, who move. Now the point he was making, if you find there are these economic activities in these regions, these young people in this region will be infected, yes, but they are not moving. But then you might find some regions are more contributing regions than receiving regions. You see? So we need to look at that analysis as well.
Okay.
You see?
Okay. Now, I'm warned time is going to be against us. But I read also as part of your survey data that 90% of people living with HIV are not infected with HIV. How is it, Dr. Kamwel?
Yeah, actually, that brings in very important thinking. We say 4.7% of people aged 15 to 49, or 5% of 15 to 64 live with the virus. Means the rest are not. This is 50, 90,
75.
95.3. Or 95% are free. And as I said earlier, that our intention is to see that nobody gets infected.
Yes.
So, as a matter of fact, now globally, 25 countries in the world who have the highest burden, including Tanzania, last year launched what they call Global Primary Prevention Coalition.
Okay.
Primary prevention means underline, keeping those who are not infected uninfected.
Uninfected.
Keeping those
separated?
uninfected negative. No, not separate. Now, how to do it is different. People who are already infected, we don't want them to die
Absolutely.
because they'll get sick in the process.
Yes.
Let them get treatment. These who are free, they are not sick and they don't need treatment, but they need to be empowered to know how to prevent from getting infected.
Okay.
We need to give them education. We give them protection. We need to remove laws and other barriers that make them not behave in a way that they will avert infection.
Okay.
And therefore now, the world and Tanzania, we are committed to that we will engage every sector to ensure that it has a role to play to make sure its people remain free of HIV.
Okay.
Because now medical services, treatment is there. But now we need to get to make sure the bulk of the people remain free. This is good because we are reducing cost of treatment. To the
Because my
government.
next question was how much, how much so far has the HIV/AIDS impacted on the cost or whatever the health services, provision of health services? Being a doctor, you might tell us very quickly before I actually ask the question I was going to ask before this, which is, what is the cutoff point where one can say, okay, he or she was infected, but she's no longer infected, she's free. What is the cutoff?
Let me answer all of them at a
Yes, yes.
Roughly, it costs 110 to 160 US dollars, somewhere in the middle, to treat one person per year. Okay?
Yes.
So one day, the 1.4 million people will need to be treated.
Yes.
Multiply the 110, 120
Yes.
US dollars times 1.4 million.
Yes.
Get the figure and get to know this is what will cost the government or the country to take care of 1.4 million people. Is a huge number, very huge. Now, the only way to reduce that cost is to make sure these people who are negative, they don't get infected. It makes economical sense. It also saves people from the suffering that one gets by just being infected.
Okay.
So that's why we are also working on making sure we have money for prevention from the AIDS Trust Fund that the government has set up.
Okay.
Now, it should be known, once somebody is infected, will be infected for life. You will never change. Yeah? Doesn't mean, once you acquire the virus will be in your body till the end of your life.
Or until
end of
science discovers
Yes, a cure, which
a
we
cure
don't have.
to remove the virus.
Yes. Now what happens is the drugs prevent the virus from multiplying.
Or making more effective, less effective.
Yeah, actually the virus kills you because they attack more cells, your immunocells. So if they don't multiply, then your body replaces those cells, and it reaches a point that you have more immune cells than those which are affected by the virus. And maybe those the ones you have will go. So you remain healthy, and you show no signs of disease, but you have the virus in you.
That does not mean you are HIV free.
You are not.
That point will never come.
Gentlemen, I'm told the time is up, but it will
just
be unfair if I don't ask this question. So, very quickly, in your view, what are the challenges still for the fight against, for addressing HIV/AIDS in Tanzania? Very quickly, one or two.
I start with the resources.
Resources?
He has just mentioned it.
Yeah.
We need a lot of resources, and much of the resources is still coming from external sources.
Yeah.
Okay.
So what we are working on is to see that we generate more resources and we become more
Self-dependent.
That's number one.
Yeah.
Two, the issue of men not getting involved in the response, in the seeking treatment, getting involved in whatever we've been talking about is a big challenge.
Okay.
So we need to get men to be involved, to get tested, to get the treatment, and to help their women as well.
All right.
You know, the last one,
Yes.
young people.
Yes.
Young people. We have 40% of the infections coming from young people.
Okay.
The communities you talked about, they need to play a very active role in helping these young people to get what they should get.
All right. Quickly.
Yeah, maybe I should not repeat what Dr. Emmanuel has said, but I should say that although we are seeing the prevalence is going down, but we should also keep in mind that the population of the country is growing.
Yes.
Yeah.
So while in fact the prevalence might have gone down, it's most likely the number of people living with HIV has gone up
Okay.
because
It's a percentage.
so the
population.
threat is still there. We should not relax.
Okay.
Let's continue with the fight against
That's
HIV.
challenge.
and AIDS.
Okay. Very quickly.
Involvement of other sectors in the national response against HIV is very important, especially private sector. They employ young able people for economic activities.
Yeah.
They need to invest to ensure that these people remain HIV and AIDS free. Education sectors, our young people Emmanuel talked about, need to come on board and do the right thing, change behavior of these people in schools so that they adopt health preventive behavior so that the burden of new infections goes down.
All right. Very quickly. People living with HIV/AIDS.
People living with HIV, I think the biggest challenge, the biggest worry is about the sustainability of the national response program.
Okay.
All the things we have learned over these years, the stabilization, the trends going down, but the financing of the national response has been coming from PEPFAR and the global
Foreign
fund,
sources,
foreign sources. And we always ask ourselves, if there wasn't this support from
Or if
external
they
sources,
cut off.
or if they cut off today, what will happen to our people? That remains unanswered by
A
everybody.
big challenge.
Yeah.
Sorry, a moment.
Yes. Yes.
To that, we have started the AIDS Trust Fund.
All right.
People need to contribute to that,
To the
the
AIDS
private
Trust Fund.
sector and individuals.
Yes.
We have a phone number,
Uh-huh.
it's 0684 90 90 90.
Okay.
0684 90 90 90.
Okay.
It's the way of mobilizing our domestic.
Thank you very
foreign
much,
fund.
my panelists.
Okay.
Emmanuel, I didn't realize you were a doctor until he
Oh,
said you were
PhD,
a
not of
doctor.
medicine. I can't give
Oh,
us.
but you're a doctor, so that's all right. That's all right. You're a doctor.
Yeah.
Thank you very much, my panelists, for the valuable contribution you've made towards the discussion on HIV/AIDS. Of course, focusing on the World AIDS Day, but I'm sure the viewers have learned a lot here in all aspects of the disease, prevention, prevalence, why one region or the other has less prevalence and one or two is higher, why women are more affected, impacted than men, and of course the challenges you came up with, the financial resources, involvement of young men.
Yeah.
We should realize that the population is increasing, the number could be there. Again, the question of trust fund, funding, and government involvement, private sector involvement, which is very good, and as well as resources, which you repeated more or less what Dr.
Exactly.
Baigana said. So, viewers, you heard the views of my panelists here. It's very interesting what they've said about HIV/AIDS. It's a fact that HIV/AIDS is there, and I was very interested when Dr. Kamuela said once you are infected with HIV, that's it. It will only be made ineffective, but it will still be in your system until science discovers something that will cleanse it out.
Exactly.
So let us heed what they've said, and if possible, men should be much more involved. And when the wives are asking them to go and check, it's better you do that. It's better your position is known, your status is known earlier, because then you get treatment, and by getting treatment, you will not affect others once you take the medication. So viewers, that's the viewpoint from my four panelists here, very ably presented. And I think we should conclude here. And on behalf of my panel, Dr. Emmanuel Baingana, I will get to know you also a doctor later on. Irenius Riobia,
Yes,
Dr. Jerome Kamwera, Gregory Kamugisha. We'll get to know you're a doctor soon. And my TBC Television Center. Thank you, viewers, and goodbye.